a gastric bypass, and this is also known as a Roux-en-Y gastric bypass. We'll talk about why that is here shortly. And I'll also talk about the SADI, which I promise I'll go into what that means. All right, so there's definitely way more bariatric surgeries than these. The gastric sleeve and the gastric bypass are by far the most common in the US. Really, they're the most common in the world. And we'll talk about the differences between all of these, but know that with every single bariatric surgery, you have both an element of restriction, meaning you're literally making the stomach and parts of the GI tract smaller, so you're absorbing less food and less water. But there's also a really big change in signaling in the body, and that's between your GI tract and your brain, that's between your GI tract and your GI tract, and a lot of other body parts. And what that affects is everything from hunger to feeling full, to how your body processes insulin and glucagon and all kinds of different hormones that affect how things are absorbed in your body and your overall body function. So all of these surgeries, even a sleeve, actually has a really, really considerable effect on signaling and hormones, which not everybody knows. So anyway, let's get started with what these surgeries are. So for a gastric sleeve, and I'm just gonna go 1, 2, 3, so 1. So actually, before we even go to 1, let's talk about what things look like in a person who has never had surgery. I am not the best illustrator, I'm not the best artist, so I promise this isn't gonna be the prettiest thing in the world, but we'll try to give it a go. So basically, you've got your mouth, and then going down from your mouth, you have this thing called the esophagus. And the esophagus is a tube. It's a tube that goes between your mouth and your stomach, or basically your face and your stomach, and it helps to pass food through. It passes across this big muscle called the diaphragm. And clearly I type so much that I don't know how to spell in person anymore, but diaphragm, right there. Diaphragm separates your chest from your belly. Now we get into the stuff that's in the belly. So we've got this beautiful structure that's gonna be our best friend in all of these surgeries. That's the stomach. And then this stuff, starting after this black point, is the small intestine. And you're probably wondering, well, why aren't we talking about the large intestine too? The large intestine, also known as the colon, not really a part of these surgeries. So we're really not gonna deal with it today. The small intestine is actually broken up into multiple parts. So the very first part, which is about here, is called the duodenum. And then after that part is called the jejunum. If you were to go down further, close to the colon, this end part is actually called the ileum. And that will come into play when we're actually talking about the SADI here. So that's what a normal person's anatomy looks like. So some interesting things to mention here. The stomach can be all different sizes. It's typically one big shape, but it's an extensible bag. Think of it like a balloon almost. People have asked me how big their stomach is during the time of surgery. They sometimes wonder, oh my gosh, should I have a huge stomach? Should I have a tiny stomach? A person's stomach can fit a full-size large pizza. Pretty much everyone's stomach can fit that. So if we were to blow up a stomach, I actually have a picture of this, but someone's stomach is basically the size of my entire upper body part here. It's huge. So the size of your stomach, not so important. Super important though is the different kinds of chemicals, the different signaling chemicals that are made in the stomach that help your brain say, I'm hungry, I'm full, I'm craving something, I'm not, I feel sick to my stomach, I feel like all those things are regulated in part by your stomach. Some of those things are also regulated in the duodenum, which is the first part of the small intestine. And that is actually going to be a really big component in the SADI surgery when we get there. The jejunum, which is the second part of the small intestine, super, super important in absorbing different things like proteins, fats, carbs, and then minerals, vitamins. And the jejunum is a really big part of the bypass surgery. So we'll talk about that. And then lower, way lower down, the ileum as the small intestine connects to the colon, again, is a part of the SADI surgery. So both the gastric bypass, or the Roux-en-Y gastric bypass, and the SADI are technically bypasses. And we'll talk about what that means here shortly. So normal anatomy, now we're passing on to the surgeries themselves. All right, so when we take a really beautiful looking stomach. We didn't really talk about this, but after the stomach, there is this muscle at the end of it, also called a sphincter. A sphincter just being a circular muscle that can close or squeeze. There's a muscle there called the pylorus. The pylorus is really, really important because it actually is what controls, or one of the mechanisms that controls how quickly the stomach empties. So if we have the pylorus preserved, meaning the pylorus is still where it's supposed to be, it's still after the stomach, it's still part of the stuff that sees food and drink, then how quickly, it controls how quickly something empties, in part. So if you have a sleeve, which is when we remove about 70 to 80% of the stomach, right? So I literally free up this part of the stomach, both along the edge of the stomach, also at the top part here by the diaphragm, and on the back side as well. And then I literally lop it off with a stapler. So you're left with something that looks like that. So about 70 to 80% of the stomach is gone. And when I say it's gone, I literally take it out of the stomach, or take it out of the belly. So it's physically removed from your body. Remember, you used to have all of the stomach that could fit a large pizza. Now we're left with something that can only fit about 4 ounces at a time. That varies from person to person, but about 3 to 4 ounces at a time. Sometimes a little bit bigger, sometimes a little bit smaller. Now, the other thing to think about is, guess what? That sleeve, this is the sleeve right there, it's actually about the size of your esophagus now. Isn't that crazy? So this tube that goes from mouth to stomach, something that can fit here, right, fits here, is now the same approximately size as your stomach is inside here. Kind of crazy to think about. So you have removed a lot of the surface of what absorbs food and water, but also a lot of what produces those hormones and signaling chemicals, right? You've really, really changed the landscape, right? So it's a big, big deal. Something that's really important is to remember that we are still keeping that structure there, that pylorus, which is that sphincter circular muscle at the end of the stomach. Because this can now fill up so much faster than it could before, guess what? You can feel bloated, you can have nausea, you can have moments that really, really don't work well with you. In some people, if they have slowed emptying, something called gastroparesis, that can be a really, really big problem. In fact, there's a whole class of medications like Ozempic, Saxenda, Mounjaro, GLP-1 agonists that can contribute to slowed emptying. And if you have a sleeve, for instance, or just a regular stomach, that can actually cause some really, really major problems with nausea, vomiting, bloating, and others as well. So just something to consider. So that's number one, that's our gastric sleeve. Okay, now let's move on to our gastric bypass. So now we're not just removing a body part at this point. In fact, in a gastric bypass, depending on how you do it, nothing is removed from the body. Everything stays inside. So let's, before we move to a bypass, I also wanted to say that on average, people are losing between 40 to 65% of their excess body weight. Okay. And excess body weight, so what are we talking about? We're talking about the weight that's over a BMI of 25. So over a BMI of 25. If you calculate your height, right? We'll calculate your height. We know your height. Let's say it's 5'5". I'm just under 5'5". And I was to look on a scale, on a graph, on a BMI chart basically, and look at BMI of 25, that's the weight that we're talking about. Whatever weight you have that's over that weight is your excess body weight. So you can lose, with a sleeve, about 40 to 65% of that extra body weight. That's a range, right? So most people will lose that. Some people will lose more. Some people will lose less. The other thing to think about is that about 20% will regain weight. And that's really, really important to think about, because if we're regaining weight, why are people regaining weight? That's a really big question that people ask. Like, what can they do to prevent that? You know, all that. Some of it's preventable, some of it's not. And that's the biggest kind of bummer of all of this, is even though bariatric surgery is the best way compared to medications, food, exercise, dieting, all those things, it is the best way to lose extra weight and to keep it off. It's still not 100%, right? In any way. It's not 100% of your excess weight, and it's not 100% effective, right? So regaining weight. Sometimes people regain weight because signaling changes over time. your body adapts, and the signaling pathways that we had originally changed with surgery eventually change back. We set the thermostat back down just like we had intended, but over time that thermostat decided to crank back up again. Sometimes it's how the surgery was done in the first place. Maybe not enough was taken of the right spots. That's possible too. And then sometimes there are some reasons we don't fully understand yet. So maybe it's genetics, maybe it's epigenetics, which is control of genes. Maybe it's environmental. We also know that people's eating and physical activity habits, their medications, their other conditions, all of that can have an impact. So it's not one thing. So don't beat yourself up if you're regaining weight after surgery, or maybe not achieving all the weight loss you thought you would. There's probably more than you at play. In fact, it's pretty certain that there's more than you at play. So come in, get that checked out, get help from a bariatric surgery program. Any professional worth their salt will help you with that, and get that taken care of. All right, so moving on to a gastric bypass. Back to where we were before. Here we go. So with the gastric bypass, again, we're looking at this anatomy first. We've got the esophagus crossing the diaphragm, becomes the stomach, then we become the small intestine. So keep this picture in mind because I'm going to mess with this quite a bit here. So we've got our esophagus that's crossing the diaphragm, and we've got our stomach. I'm just going to put esophagus and stomach. And then guess what? This actually gets connected to the small intestine. So stomach, intestine. And this is the crazy part here. That's stomach too. Okay, so that's a Roux-en-Y gastric bypass. So the reason that it's called a Roux-en-Y, it's named after a French dude, of course, and then it actually looks like a Y. So you actually see that Y formation there. That's why it's called a Y. Why? Because it looks like a Y. Anyway, so what we do with a gastric bypass, and this is how it looks in textbooks, by the way. It is super not what it looks like in the OR, okay? So you kind of have to suspend disbelief a little bit in how this looks. But we're we're actually dividing the stomach. So you're like, wait, there's stomach here, how is this all working out? We take the stomach here and we actually divide it up here at the top. And we leave a really little pouch, about 30 to 60 milliliters, which is just a couple of ounces. So something really, really small up top. That's the stomach there. I bring up the small intestine and I attach it there. And then we leave ourselves with a limb called the Roux limb, Roux-en-Y. Roux limb is here. And that is the path that sees food and drink. Until you get to the other small intestine and the colon and so forth. Guess what? All of this, I should probably use a different marker, huh? 1 second. There we go. All of that gets bypassed. So the majority of your stomach gets bypassed, and then depending on how long you actually make this, it can be 75 centimeters, it can be 120 centimeters, it can be 150 centimeters. It just totally depends on how much is getting bypassed. Yeah, and different people do different lengths, and that can really affect your absorption a lot. So again, we're talking about restrictive, smaller space, right? Smaller size, but massive changes in how things are getting absorbed and massive changes in how things are getting signaled. You're probably wondering, why on earth would we keep this stomach here? What is it doing there? Why is it hanging out like that? So the stomach is actually connected to still blood supply. Okay, still has blood supply, not like we're leaving a dead stomach in there. It's nice and perky and happy. But really, really important is after the stomach, there's actually plumbing structures that attach it to the pancreas, which is back here, to the liver, which is way up here, and to the gallbladder, which is here. If we don't leave this here, and if we don't leave this limb attached, we could really mess someone up, because there would be no way to drain the liver or the pancreas or the gallbladder, and you can kill someone that way. So that's not a good thing to do. So we leave that there, okay? And that area becomes kind of a drain. So that stomach and small intestine, think of it like a muscle you don't use. Like let's say you just stopped using your right leg. well, your right leg would become all puny and wouldn't really work, and when you tried to use it, it really didn't work. So all of the signaling and all the hormones and all the stuff that used to work in the stomach and small intestine doesn't get used. Doesn't really see any action anymore. So it does actually atrophy. It does actually get smaller. It does actually stop functioning as much, and that leads to massive changes in how your body signals. So the gastric bypass, an extremely strong way to treat things like diabetes, NASH, which is fatty liver disease, any other kinds of metabolism issues, so high cholesterol, high blood pressure, all those things. Because you have bigger changes happening in a bypass, you are going to lose more of your excess body weight on average. On average, people lose about 60 to 80% of their excess body weight. So not 60 to 80% of all of your weight, again, it's just that extra weight, right? And then regain potential is down to about 10%. Again, in a lot of ways, this is a more powerful tool for losing weight and for treating weight-related conditions, right? But with everything comes a cost, right? You can see that here, we took out 70-80% of the stomach. Okay, that looks like a lot of surgery, but that's kind of manageable, right? Somebody else could draw that if we tried, but that looks more complicated, and you're right, it is. With this surgery, there are bigger risks, right? There's a couple. You're absorbing a lot less fluid, you're absorbing a lot less nutrients, and those two problems can add up to a lot of grief for people. So if they're not drinking at least 64 ounces a day, they're not taking their daily vitamins, you can really land in a lot of trouble, even complications that can lead to death. So these are very, very serious surgeries, and they're really, really serious to follow up on and to take your vitamins and follow up with your team, all of that. There's other problems. Anytime we're rearranging the plumbing inside someone's body, we're also moving the things attached to them, right? Like the blood supply and the drainage systems, the lymphatics, all of that. So there's actually chances for hernias to occur even on the inside. There's more chance for scar tissue to form on the inside. There's more chance for these connections to leak, or these connections to scar down and form something called a stenosis, which is a narrowing. So there definitely are more risks associated with this surgery. However, they're still really low. So less than 1 in 20 on average in the US will have a complication from even this surgery, which is pretty darn good. It's actually one of the lowest rates in surgery altogether. So that's pretty exciting. Okay, so that's a bypass in a nutshell. Granted, there's a ton more we could talk about, but that's a bypass in a nutshell. And then a SADI. So let's talk about a SADI. So what is a SADI? So SADI stands for single anastomosis duodeno-ileal bypass. Really complicated, but let me break that down. So single anastomosis, meaning one connection, okay? In a sleeve, no connections. In a bypass, 2 connections, one up top, stomach to intestine, and one down here, intestine to intestine, okay? Single anastomosis means one connection. So it's kind of in between the two, right? One connection. Duodeno-ileal bypass. Bypass meaning that we're going to be rearranging things. We're going to be creating a detour. And we're actually going to be creating that detour between the duodenum, that first part of intestine after the stomach, and the last part of the intestine. That's closer to the colon. So kind of interesting there. All right, so let's draw that out. The other fun part about a SADI is it actually involves a sleeve. Yeah, so let's draw that out. So we've got our esophagus crossing down across the diaphragm, which I should probably have drawn here too. There we go. And we're actually going to create a sleeve. So a sleeve is part of this, right? And then here's the interesting part of it. We're actually going to create a connection to our duodenum. Okay. This is not the prettiest picture. I'm so sorry. You're gonna have to forgive me for not being a good artist. I somehow made it through med school anyway, through surgery. So this is what a SADI looks like. That all kind of looks like a funky, weird, I don't know, octopus or something. You're like, what are all these things? You're gonna have to imagine that these things are connected down below to other structures. They're not just hanging out in the breeze. So first part of a SADI is to actually do a sleeve. kind of interesting. Why do we do that? So we do that for a lot of reasons. We do that in order to preserve the changes that occur when we actually cut out 70 to 80% of the stomach. Granted, when we're doing a SADI, sometimes we make it looser than what we do with a sleeve. So there's that. And with a sleeve, with this sleeve, it still has those chemical and signaling changes as well as the restriction, but now we're adding a bypass component to it too. We do not place the bypass into the stomach for a couple of reasons, but we actually put it just past the stomach at the duodenum, which is the first part of that small intestine. So we actually make an opening in the small intestine, okay? And then we bring up way lower down in the small intestine than we did for a bypass. We bring up this last part of the small intestine up to make this connection. And the way that we keep this one connection rather than two is we don't disconnect it. We bring it up like a loop. So imagine if you had a rope. Actually, let me just show you one here. All right, so you've got a string, right? If we were to bring up this string and connect it up here, that would be that, right? We're just connected, and that's that. In order for me to connect something below, I'd have to use a different piece of string like this one, right? In this case, we don't bring up the end. We actually bring it up like a loop. So it connects like a little loop of string, and you only need to make one connection as a result. Yeah, so it's not end to end, it's a loop. So yeah, luckily I was wearing scrubs today. That worked out well. So we bring the last part of the small intestine up as a loop to connect it to the duodenum, which is the first part of the small intestine. So that becomes our DI part of the SADI, right? Single anastomosis, one connection, duodeno-ileal bypass, SADI, okay? So why on earth would we do this kind of a surgery if we already have a sleeve and we already have a Roux-en-Y gastric bypass? Well, there's a few. I'm so glad you asked. So this is actually an updated version of something called a duodeno-ileal switch. Also called a biliopancreatic diversion. Sometimes it's called a DS. There's all kinds of ways to name this. But traditionally speaking, you would do the sleeve, you'd actually bring up the ilium like that end, and then you would reconnect, you'd make a second connection down below. When we do that, people have diarrhea, they have really bad absorption issues sometimes, bad problems with dehydration, and it can even lead to something called short gut syndrome, where basically people don't absorb enough nutrients to keep themselves and their gut healthy. That doesn't happen to everyone at all, but it does seem to happen to a fairly significant population of people who get the two connection version of this. So if we bring it up like a loop, guess what? We're not cutting any bridges. We're actually allowing things to go both ways if they need to. It allows a little bit better absorption, and it's a little bit less risky in general. The other part of this is that you're making one connection, not two. Anytime you make one connection and not two, you have less risk of problems with those connections, like bleeding or that narrowing that we talked about, or scar tissue, all those things. So this is just an updated version of a duodenal switch, or a different version of a duodenal switch. So for all intents and purposes, it's similar to a gastric bypass in a lot of ways, but also you'll notice incorporates a sleeve. Okay, so what kind of body weight loss can we expect with a SADI? This varies a little bit more than either of these two. So typically we see about 70 to 90% of excess body weight, sometimes more. And and then regain is actually less than 10%. And why would that be the case? Why is this even more powerful in some cases than these other two surgeries, right? The reason why is because the amount of bowel that we're bypassing is a lot more. So there's different ways of people doing the SADI surgery, but in general, you actually count out a very specific amount of small bowel between the colon and where you actually make this connection. Usually it's around 300 centimeters or so. So basically everything up to that point, let's say it's here, you're bypassing all of that. So it's a much longer bypass than you have with a Roux-en-Y. So for that reason, you typically see more weight loss, less regain over time, and greater effects on both absorption and signaling in the body. So it's also a very effective treatment for diabetes, high blood pressure, high cholesterol, all kinds of things related to metabolism. So yeah, so those are the gastric sleeve, the Roux-en-Y gastric bypass, and the SADI. And just for all of our information, these can also be done open, laparoscopic, robotic, in any modality. And yeah, so I hope that this was super helpful. And if nothing else, it really helped me to showcase my great drawing skills for you. But anyway, thank you so much for joining us. Really appreciate it.